Uh, Today we are just now going to start the third episode of Rssdi case files. Rssdi team, I welcome moderators, Dr. Subhan, our upcoming Dr. Rakesh Sai sir. I think he will be just joining. And we have again a great speaker and great visionary man, KVS Hari Kumar. So, Dr. Jeffers, and then we can start. Our kind of can you share for our moderators? Please share the slides.
Ankit, you can share the slide. Yes.
Yes, share the slides. So I will just introduce Dr. KVS Hari Kumar. He is the MD Medicine and DNB. He is a consultant endocrinologist at the Magna Center and the Fernandez Hospital of Hyderabad. As you see a long list, but he, to his credit, 225 publications in peer-reviewed, PubMed, and index journals. I think for all the Rssdi members, he does not need any introduction further. You can share the next. Can you share the next? Dr. KVS Hari Kumar will present today very interesting cases, and then we will discuss in between. Then again, there is Dr. Rajiv Chawla, sir, today's moderator. I think there is again a very long list. Everyone is aware about all the things he has done for the Rssdi and for the society as well.
Good evening.
So I think I'm not going to read out all the details. So I think, sir, welcome, sir. And then please share the PPT of this data for the Subhankar Chaudhary, sir. Ankit, please share. Yeah. I think again, everyone is aware about a well-known figure, that is Professor and Head Department of Endocrinology at the Kolkata, Dr. Subhankar Chaudhary, sir, and he again remained in the past. I think he is at present the chairman of the Rssdi West Bengal institutions and other things you are seeing here, and his research papers are very, very illuminating. So welcome you also, sir, and Dr. Rakesh Saib. Sir, CB, can you share? Ankit? Next. Yeah, so I think again, Dr. Rakesh needs no introduction today. Our stage is coming up, and MD, FSC, other things, and Professor and Head at Department of Indo and list here. So everybody knows him, so I'm not going to waste time for that. So with that, I think I can invite Dr. Rajiv Chawla, sir, to say a few words and about the KVS Hari Kumar, and then he can start the presentation. Chawla, sir.
Good evening. Thanks, Dr. Singh, for all those kind words. And all the speaker and the moderators are already introduced. It is wonderful being part of such a elite board, because we have Dr. Shubhankar, Dr. Sahai, and Dr. Hari, all three top endocrinologists in this country. And Dr. Hari, I'm sure, is going to present something very, very unique, because it is a Rssdi case file study. So we always try to put up some very, very rare cases on which we can have later on some discussion. So with that brief context setting, I'll request Dr. Hari to please do the case presentation, and then we will have discussion and maybe certain cross questions. Dr. Hari, please.
Thank you, sir. Good evening, everybody. It is actually a pleasure to get the invite and to speak in front of the teachers. Shubhankar sir is interested in fat, and I'm sure we will discuss something of that as we progress. because common garden variety cases, but may turn out to be a uncommon things, or maybe what we generally overlook is what we will be discussing in some of these in the next 30 to 45 minutes. I hope I am audible and my slides are visible, sir.
Absolutely, sir. Please carry on.
Okay. So this is about a lady, reasonably, I would say young lady, 28-year-old, who was referred for us with a poor control diabetes actually. She was a known diabetic for 12 years. And when she presented to us, her A1C was 11.4, using almost 110 units of insulin, basal bolus regime, and multiple OADs. And despite that, she was not controlled, and that is why she was referred to us. To start, to go back to the history a bit more, she was diagnosed when she had osmotic features. Initial diagnosis when she had symptoms, that time typical osmotic symptoms were there. Random sugar, she remembered, was about 340, and A1C at that time was about 12%. But she and her mother definitely says that there was no history of admission that time. She was always managed in the OPD basis only. We don't have any definite history of ketones being checked or not checked, but this much was clear that she had typical osmotic symptoms, but always was managed in the OPD setting. And she does remember that insulin was not started initially. Initial about good 3 to 6 months, they have tried some OADs, and which did not result in any much improvement. This was almost when she was about somewhere closer to puberty, 15, 16 age group. Maybe in the 6 months to 1 year later, she was started with a basal insulin to start with. And all throughout these 10 years, the insulin doses kept on increasing, but there was no episodes of DKAs, neither the episodes of hypos all throughout. There was definitely a suboptimal control all throughout. Most of the times, whatever her A1C was in the range between 10 to 12. There was some weight loss, which the mother noticed, and with a baseline of about 60 plus, and some unwanted hair, some eruptions on the hands were noticed by the patient and the mother. More interesting was mother complained that the daughter is not looking good. She is at marriageable age. As such, diabetes is a label which is not a, comfortable label for the mother. But she was not happy with the way she was looking at, as the diabetes is not controlled also, and then it progressed. So further increase in insulin and added acrapid thrice daily, but no control, and A1C never below 10. This was the general profile, but there was no other major complications of any micro or macrovascular which the patient had, and no other comorbidities. So at this time, when she presented to us at maybe about 10 years history of diabetes with poorly controlled despite using about 100. Can we have some discussion here? What type of diabetes is this?
It's Dr. Hari Kumar.
Yeah, do we have information on exact BMI? Because height you haven't specified.
Yeah, the BMI was 19.6.
19.6.
Yeah.
So she's a lean, thin diabetic.
Lean, thin diabetic.
10 years,
absolutely.
Close to 10 years. There's no definite history that she has ever had ketoacidosis or DK, but she has been having persistent hyperglycemia in spite of earlier trial of oral anti-diabetic drug and on glargine.
Correct.
Has she been regularly being followed in some unit to uptitrate the doses, or no?
Yes. It was uptitrated. As I said, the record shows that started with a 10 units of a glargine to start with, and reached 110 units of basal bolus when she reached to us, with a acrapid addition thrice, and almost like 30, and some 20 units of glargine was the one which she was taking.
So at almost 60 kg weight with a BMI of close to 19.5, she was already requiring around 120 units. That means almost 2 units per kg per day, and still she didn't have a good glycemic control.
Despite that, she didn't have.
Perfect. Over to Dr. Shubhankar, sir. Dr. Sahai. Yeah,
no,
Dr.
I think.
Yeah, sir.
Yeah, sorry. Yeah, go ahead.
Go ahead.
Yeah, please go ahead, sir.
Dr. KVS Hari Kumar, I think, did you go for the ultrasonogram for the pancreas also in this case?
The previous ultrasound, which was there, I've not put it. Yes, ultrasound was done, which showed a normal thing, slight mild hepatomegaly and a fatty liver was there. There was no splenomegaly, but pancreas was normal on ultrasound.
Oh, so also what was the level of the C peptide?
C-peptide was never done at that point of time.
GAD was
Okay.
negative.
CAD was negative. CAD, we have checked later, but it is negative. Yes.
It is negative. Okay. Proceed, sir.
So definitely, when you look at the types of diabetes, GDM obviously nowhere in the consideration. If you look at the type 2, age of onset, young age, lack of ketones, definitely still of this duration. Very early OAD failure, technically LADA, you require some more age, but maybe atypical variants. And by and large, actually, if you look at the definition of type 2, it is a definition of exclusion. That is, you don't have an antibody, you don't have pregnancy, you don't have a secondary disease leading to diabetes, then only you can label it as type 2. So ideally, you should exclude a lot of other things before you reach to a diagnosis of type 2. So we should still consider this being the commonest. Type 1, because of the age group, lean, but all throughout, she never had any ketosis despite having poor control. May still, maybe in early days, at presentation didn't have ketosis. We can still consider maybe picked up early and almost 6 months to 1 year, she was on insulin, which could have prevented some ketosis, but less likely possibility. Secondary diabetes, maybe some other disease which is underlying, possible because of atypical features, associated hirsutism and weight loss despite using this much of insulin and poor control over almost 5 years duration of diabetes. So definitely this, we should consider some other reason which helps or which looks at this possibility of a underlying diabetes, the etiology for the diabetes. At any point of time, anybody wants any moderators or the panelists, please intervene so that we'll have a healthy discussion, and idea being educative action. So when you look at somebody comes with a diabetes with a poorly controlled, commonest one, patient related, because they are not compliant enough, they are not looking at whatever is the diet, whatever is the other thing. So we should consider the patient related actions first. Surreptitious use of antipsychotics and glucocorticoids. Most of the times patients don't complain these things. They may be taking treatment for some other disease. They may be taking some creams. So always look at these, and underlying stress and other conditions. Maybe puberty also would contribute to some extent. So some of these. Patient is using 100 units of insulin despite that poor control. Is the insulin properly stored? What is the technique of injection? Is it at the same place of absorption? All those things also matters at this stage. Whether she has any insulin antibodies, which is requiring to prevent the action, any other coexisting autoimmune disorders. Rare condition of subcutaneous insulin resistance also has been reported, where you do a IV, you give IV insulin, that it controls beautifully, but the moment you lead to a subcutaneous, it may not actually work. But nevertheless, as I said, these are rare, but we should be considering some of these things whenever the patient has poor control of diabetes despite using so many units of insulin. And the most neglected is the disease related, actually underlying some other condition, maybe all endocrine, any endocrine hormone excess disorder will lead to a hyperglycemia, be it your Cushing's, acro, thyrotoxicosis, FEO, any of these things can lead to HIV, heart, or any CKD, any CLD sometimes can lead to a significant insulin resistance and leading to a higher requirement. And some metabolic disorders like lipodystrophy or insulin resistance syndromes, these are the things which can actually lead to some of these higher requirements of it. So when we looked at the...
Just a comment, Hari.
Yes, sir.
In CKD, more often we see a state of lessened insulin requirement, especially in more advanced stages of CKD. But I fully agree, there are small number of cases where there may be significant insulin requirement or significant increase in insulin requirement. Right. Please go ahead.
Correct. Absolutely. So we looked at all that 7 to 10 years history, not much of an issue, compliance fairly okay, storage, administration, all those okay. This was the BP, this was the facial appearance of the patient. If you look at it, acromegaloid features, severe acanthosis, some amount of prominent forehead, hirsutism, and what is staring is actually the loss of the subcutaneous fat. Actually, if you look at it, it is mostly, I mean, something like a prominent, which is their cheekbones, prominent forehead, which is there coming at the staring at. Some of the clinical clues which can help in the secondary diabetes in finding the diabetes, obviously acanthosis, we'll come to this part later, but
So, Hari,
acromegaloid
so
features,
these are
hirsutism,
not our
warts,
patients.
striae, these are not our patients, this is our patient.
Right. Yeah. Okay. Do we have any more photos of this young lady?
Yeah, this is
For
the
example,
ones.
do we have the
Yeah.
arms? Okay. Okay.
Arms
Very
and
So-
good.
legs and how the fat distribution is.
Okay. Okay.
This is the photo of the arms, which looked at the eruptive xanthomas, which are there. You can see slide these ones. The
Okay.
GAD was negative. The lipids showed triglycerides of 526, total cholesterol of 225, total testosterone 78, A1C of 11.4, microalbumin slightly increased. There was no retinopathy. And
So, Hari, this
Yes.
picture is of lady.
yes.
Quite strange, absolutely very catchy diagnosis. Yeah, sir, proceed.
So other endocrine evaluation, ONDST, just for the sake of completion, we did that was negative. IGF-1 is normal. So at this stage, actually, for some, I wanted the panelists to discuss something like how do we assess for insulin resistance at this level when somebody is using actually 100+ units? I mean, most of the, like say your HOMA IRs and all will not work well at this stage. And you are having a systemic insulin, basal insulin into the system already.
Yeah, I think assessment of insulin resistance is difficult in presence of diabetes itself, where we assume, because the insulin resistance as by HOMA IR, for example, is measured by looking at the insulin levels. The supposition is if you have insulin resistance, the body will try to compensate and produce more insulin. But when you have diabetes, you have some amount of beta cell dysfunction as well. So that insulin response will be not in proportion to the resistance or in otherwise healthy individuals. So clearly, we will not have a significant elevation of insulin levels whenever we have got someone who has already got diabetes, and especially type 2 diabetes. So that does not help us. And in presence of gross hyperglycemia, there is additional element of beta cell functional impairment. So which will again further give falsely low values for insulin or insulin resistance. The standard method, of course, is hyperinsulinic clamp. But again, that's not feasible. We cannot do that clinically for practically any patient. Even in a teaching hospital setting, we hardly can do that except in a research setting. So what we are left with in people who are on insulin, maybe to look at how much insulin this individual is taking, having made sure that insulin injection technique and all are all okay. So maybe you will have, or others will have some other points to add.
I think sir is perfectly right that especially in late stage of the disease, this patient is already having type 2 diabetes close to 10 years. Well, early stage of the diabetes, you may still correlate with higher insulin level or C-peptide levels. 10 years down the line, once she's already losing weight and she's almost totally insulinopenic, although there are symptoms and signs suggestive of insulin resistance in this patient with acanthosis, which is significant. She still may have higher levels, but No way we may be able to quantify that she has insulin resistance. Only clue may be, as you very rightly said, Dr. Hari, based on her per kg calculation of insulin, that if she's requiring close to 2 units per kg per day or more than that, she falls into the category of insulin resistance. Otherwise, 10 years down the line, with almost total insulopenic phase, beta cells already lost, severe hyperglycemia, as sir very rightly said, when with beta cell toxicity, no way you will be able to get any value which may suggest there is insulin resistance. Very true. Dr.
Absolutely.
Sahai.
I would also agree with that. Agree very much with what Dr. Shankar sir has said and Dr. Rajiv Chawla has mentioned that, at this stage, it is more of the insulin use, that the amount of insulin that is being used is an indicator of the insulin resistance rather than looking at a calculation of HOMA-IR, which is a lot of assumptions are there in that. So we certainly cannot use that at this stage of the problem, and it's more of the insulin that is being used, the dose of insulin that is being.
So may I ask
Dr.
one
Hari,
question?
Yes, sir.
yes.
Yes, Dr. Pratap.
Can we use that surrogate marker of low HDL and high TG as a marker of insulin resistance in such category of patients?
Possibly yes, but it will not quantify. I mean, we cannot quantitatively say this is the
what I
amount
said.
of insulin.
No way you can quantify in this patient, except the doses. You may have some idea that based on per kg requirement is say double of weight. It is already close to 2 units in this patient with 110, 60 kg weight. She is still hyperglycemic. So that gives us a clue that there is an element of insulin resistance.
And that triglyceride HDL ratio is probably as good a marker as your clinical markers itself. You're having significant acanthosis, which is itself suggesting that, and the triglyceride HDL ratio, which you're seeing right in front of us on the screen itself, we can say that it's very high here, showing that it is certainly a good correlating factor.
Okay.
Definitely, we are clueless about defining the insulin resistance, but by and large, the definition, if you look at it, greater requirement of insulin to elicit the biochemical response in tissue, cell, or species, wherever it is. Okay. So in such simple setting, it is actually the practical definition which is more relevant. If anybody normal insulin requirement is about 0.5 to 0.7 unit per kg per day, insulin resistance is considered when you have 1 to 2 unit per kg per day as a requirement to keep a normoglycemia. Severe insulin resistance, if you are requiring 2 to 3 units per kg per day, and extreme insulin resistance, if you are requiring more than 3 unit per kg per day. Why it is important is whenever anybody requires more than 1 unit per kg per day, definitely you should keep, the eyes and ears open to find out something else is happening in the patient, not a common garden type 2 DM. So this is how we define insulin resistance based on the total daily insulin requirement. And causes of increased insulin requirement, these are the different syndromes which are there, the insulin resistance types, drugs, endocrine disorders, hypersensitivity, increased insulin clearance, all those things, which are commonly things what we should be looking at whenever somebody is having an increase in the insulin requirement. Now, the 3 types of insulin resistance syndromes, just to make everybody aware, the type A is something to do with the insulin receptors. The typical Heron syndrome is the hyperandrogenism, insulin resistance, and acanthosis nigricans. And mostly they have the infertility or menorrhagia or sometimes amenorrhea mostly. They may have normal or low triglyceride levels. That is important to understand. Type B is the one where there are antibodies to the insulin receptor preventing its action, seen both in males and females, has severe acanthosis. Whereas type C is the one which is the post-receptor defect. So either the receptor is problem, antibodies to the receptor, or post-receptor, that is a type C. And again, there are a lot of overlaps between the Hayran syndrome, PCOS, type 2DM, all these things. So in a patient who has got so much of higher insulin requirement, when should you suspect a lipodystrophy? Usually when somebody has got a positive family history, definitely yes, in siblings, because most of them are autosomal recessive. Some of them have autosomal dominant inheritance also. Muscularity with loss of body fat, voracious appetite, because they don't have leptin. So right from childhood, they have lot of appetite. So every time they are eating. Acromegaloid features, prominence of umbilicus, may have umbilical hernia also, significant acanthosis, and irregular menstrual periods. The metabolic features will remain the same: severe hypertriglyceridemia, the fatty livers, hepatomegaly, and some of the partial lipodystrophies, they may have upper torso, maybe looking muscular, and lower, the fat is in the lower ones, and vice versa. Because some of the times when you don't expose the patient completely, you may have actually a Cushingoid facies on top, but maybe having a dystrophy in the bottom. So it is important to look at the patient as a whole. And these are more of a, what we look in the clinical is early age of onset of diabetes, especially in the second decades, high insulin, especially with normal or low BMI. A 100 kg man requiring 100 unit is okay, but a 50 kg girl requiring 100 unit is just not okay. Significant family history and unusual lipid profile. We all understand that diabetes will have some amount of hypertriglyceridemia, maybe 200s, 250s, like that. But somebody has 700, somebody has 800, or maybe at 1200. We should always, the eyes and ears should be open. Muscular looks of the patient, they are not typical, especially for the females. They don't have that feminine appearance. So at the face of it, they may not complain, as what I've said in the history. The mother actually noticed that the patient is not looking like a girl. So those are the things which should be picked up. And hepatosplenomegaly in some, when it is a significant stage. So these are the things which should give us a clue that the underlying diabetes is not what actually a typical type 2 or a typical diabetes profile. We may be having something else. This is the image of the body fat of the DEXA of the patient. Can we have some discussion about, sir, how to assess body fat in the clinical practice?
Dr. Hari, before you go to this, can you go back 1 or 2 slides? We will like to discuss here, maybe one more slide. So, yes. So one thing is very sure that she is requiring almost 2 units on which she still has persistent hyperglycemia. So maybe her requirement is close to 2 to 3 units per kg per day to get close to 7.5. So clinically, if I have to ask you, let's forget about the further investigation and all that. Does she fit with type A or type C? Because seeing her BMI, she fits into type A. But seeing her overall profile, that she has symptoms of acanthosis, she's not obese although, and she has typical Heron symptomatology. I think she fits in type C. So let's discuss here before doing any auto antibodies or receptor antibodies or looking for other things. Where do you like to put this patient? She clearly has insulin resistance. Based on her BMI and overall presentation, she looks like type A, but based on overall symptomatology, she fits in type C minus obesity.
We consider type C. Let others, Saras.
Dr. Sahai, you want to say something here?
Well, I think
she looks like typical type C obese, but she is very lean. BMI is 19, already losing weight.
Yeah, I think the important point is that she's lean and thin, with all the other features, with significant acanthosis and I think the most important point is the fat loss and the typical facial appearance, which gives us a very good clue about the insulin significant insulin resistance. So I would I think it fits in with type A very well, sir, but because she's not obese also, and she has the typical, because type C is more of the garden variety obese individuals we see, and all those with PCOS, women with PCOS would rather fit into more into that type of insulin resistance. Whereas type A are the ones which have a significant defect at the insulin receptor itself. So that's why they have that significant degree of insulin resistance while not being obese. So
But
I would
TGs are normal. TGs are
I,
high, quite high.
TG, sir.
yeah, I would. The TG level is
TG
not
has
not
typical
high. Yeah.
heron symptomatology with that typical hyperandrogenism, that typical face, insulin resistance, acanthosis. PCOS, we don't have any information. Dr. Hari, if we
It's a,
can have some
l-
information on our cycles and
she
pattern of.
had she had menarche at about 15 years of age and
Okay.
irregular menses, say once in 3 month cycle. It's a oligomenorrhea, once in 3 months cycle.
Although we see that her androgen levels were a little on the higher side, the testosterone levels were
It was
70.
not very high,
I
not very high,
indicated. Yeah, but it was slightly on the higher side.
slightly on the
But
higher
I
side.
would be inclined towards putting her in type A insulin resistance.
Okay.
That's
Dr. Shubhankar, sir.
So, I mean, do we need to put her into one of these slots only? Because Dr. Hari has given us other clues as well.
Okay.
So she may not be part of any of these. Could be something more. So
He's going
But
to
if you-
unfold
if
the
you
story
want
further,
us-
I think.
yeah.
it's more
Okay.
looking
If you
like the
want-
lipodystrophy syndromes, which are again
Yeah,
a little different from these
these
three
three
types that
insulin.
we have.
I agree.
Yeah.
Over to Dr. Hari.
Yes. So that is why it was not fitting into a typical insulin resistance syndromes actually. And her appearance, her rest of the characteristics did suggest the lipodystrophy.
True.
That is why actually we looked at the body fat estimation. Now, clinical parlance, I mean, this is the DEXA image definitely. How do we assess the body fat? Not everybody will have DEXA in their hospital or this thing. So we definitely have different methods of looking at body fat. BMI is one of the easiest done for everybody. That is okay. It is indirect one. If somebody can have a calipers and then can just look at the subcutaneous fat, maybe behind triceps, behind scapula, that is easily doable to some. But it is I would say, less validated or less robust because of the methodological issues. But nevertheless, to document, it is of a reasonable good one. Bioelectric impedance analysis does give you some number, but has a lot of variability to it, fluid, fasting, body, what you call the clothing, lot of issues. So not very well standardized. As far as the, best methodologies to assess body fat, DEXA, CT or stroke MRI, 3D body scanning, or deuterium dilution or hydrodensitometry, which is the gold standard, but definitely done in more research settings. Clinical setting, whenever you suspect anything about loss of fat or a regional loss of fat or a distribution, the best thing is DEXA. At least most of the tier 1, tier 2, even tier 3 cities have the DEXA. You just have to ask them to do a body composition. I will show you in this patient. If you look at it, the yellow is considered as the fat, the blue is the bone, and red is something like a overlap the soft tissue. Now you see a speck of fat only at the pubic region, somewhat a very minuscule specks here, and rest of the entire body, actually there is no fat. The another important thing, you see this, which is like almost a huge liver which is going up, almost like a hyperdense in that image. What is coming? It is like a good amount of hepatosplenomegaly and almost complete total absence of fat. What is there in the patient? Any comments or
I
anything?
think she typically that way, after seeing this picture, typically falls into the category of lipodystrophy, one of those autosomal recessive type, and where there is hardly any fat, and you rather see more muscular development because of deposition of fat, maybe into the arm muscle and also at times into the leg muscle, and excessive fat getting deposited into the liver the way you have shown that hepato and splenomegaly. Of course, it can be further worked up by a fibroscan to look for the amount of steatosis and all that. But typically, the way this image is coming up, there is hardly any fat. So this patient exactly fits with lipodystrophy, maybe congenital variety. Dr. Sahai, Dr. Chaudhary, sir.
I would just like to take on Dr. Harikumar's comment about body fat assessment. I do fully agree that DEXA is one of the gold standards, but still it requires a sophisticated machine. There is small amount though, radiation exposure. Bioelectrical impedance is not as validated, fully agree. But I think for most poor people like us, and we do have DEXA in our institute, but on an OPD basis, we often can get a fairly good idea of overall body fat percentage, much less of information about regional body fat differences. We still can get some with a bioelectrical impedance, and we have done some studies to show a correlation between DEXA determined body fat and bioelectrical impedance dependent body fat, and found that they fairly correlate in many people with type 2 diabetes. However, again, DEXA would be the best thing to have.
Yes, absolutely. It is, when, as they said, at least to start with, whenever you suspect, it will give you a clue point whom to refer, maybe for DEXA, and mostly for regional fat distribution, DEXA will be the best, because some of the partial lipodystrophies, when you're suspecting, then your bioelectric impedance may not give you, because it just gives you the overall body fat of an individual.
Yeah, because
Okay,
some of the machines of the bioelectrical impedance also give you the arm fat and the trunk fat and that sort of distribution. It depends on the type of equipment that you're using. Some of the higher end ones do give you the each limb fat distribution and all that. But as Hari has said, that DEXA certainly is a good sort of test, in particularly in such a scenario when you're facing a scenario like this. But in the general OPD, we would still depend a lot on the bioelectrical impedance. And as we were discussing, that I think the first few, I mean, if you look at the severity of insulin resistance, how it keeps increasing is with the loss of fat in the arms and the peripheral fat initially. Then the central fat is preserved for a longer period of time. At least in those milder varieties. In the more severe ones like this patient we are hardly seeing any fat at all. And that's complete generalized lipodystrophy, which is quite obvious from the DEXA film that you're seeing here.
So, Dr. KVS Harikumar, can I just say that this is a very interesting but very rare case. And what I learned so far, that the diagnosis of lipodystrophy is usually we can made with the clinically based on the history, the body distribution of the adipose tissue, regarding the physical examination also, and metabolic profile is very, very important again. So this can we suspect it in any person with partial or complete lack of subcutaneous adipose tissue. But I think that such diagnosis is quite often delayed because it is so rare, and most of the physicians don't have much idea about it. So I think these points are okay.
Yeah, so I think the important point is to make everybody aware that we need to keep in mind this fact that there could be some patients who have very significant insulin resistance. If they have a very high insulin requirement, we should keep our eyes open to look for the fat distribution, see for these signs which could indicate that there is an abnormal fat distribution. And the milder, the partial lipodystrophies are much more common. I think when you look at their fat distribution, you'll find that many of them have partial lipodystrophies. The complete ones may be very rare, as as you highlighted that. But I think as we go along, Dr. Hari is going to tell us a little more about all the different types of lipodystrophies, and I'm sure
there are actually studies which have said that 5% of so-called type 2 DMs who are requiring more than 100 units were actually partial lipodystrophies.
Yeah.
Because there are population-based studies.
Yeah. So, Dr. Sahai, what you told, I think that this is if the physical phenotype we are missing, then if you are getting the hyperglycemia, insulin resistance, and severe hypertriglyceridemia, and that is non-responsive to the therapy, I think these points are clinically very much important to pick up such cases.
Yeah.
Yeah. So this is what the message is. Yeah.
Yeah. Poor response to insulin. Yeah.
Yeah. Yeah.
I would just like to add, I think at some point, Hari also did mention that this is likely a case of generalized lipodystrophy. But again, as Dr. Sahai said, that partial lipodystrophy is more common. And this partial lipodystrophy may not be visible as in this individual on the face itself. So there will be individuals who will have primarily loss of fat in the gluteofemoral region. So unless you strip that individual, you will not be able to detect. And so the importance of clinical examination comes in. So if you have got a patient who is relatively non-obese or lean and requiring very large doses of insulin, and you have a lipodystrophy at the back of your mind, you need to examine from head to foot. You do not know exactly where the fat loss will be. So it's for some, it may be excess body fat in the upper half of the body. For others, it may be loss of fat in the lower half of the body, and so on and so forth. Right. So we can go ahead from my side.
Dr. Hari, please continue. Yeah.
So when you look at the types of lipodystrophy, basically it is generalized or partial. First is generalized, that is whole body, or partial is a particular portion. Okay. Now on to your left, that is the A and B. If you look at, both are, and both generalized and partial are either congenital or acquired. Okay. So loss of the entire fat, there is significant acanthosis, umbilical hernia, hepatosplenomegaly. Okay, more muscular looking appearance. Okay, the same acquired variety, almost the same. Panniculitis is just inflammation of fat, and again umbilical hernia, what the onset is. Now, most problems come actually in the partial varieties. If you look at this image, there is loss of fat in the gluteofemoral region, as Sir has said. These like muscular looking legs with actually a obese lady on top. I mean, double chin, rounded face. So they are the ones, because of insulin resistance, they would be considered like a Cushingoid features. But unless you see this portion, it is actually a loss of fat here. And vice versa for this lady. It is lost from the upper torso, whereas the legs are more or less like a typical female legs. So it is important to look at a particular portion of loss, which still will have the same metabolic derangement, maybe at a lesser level, but definitely will have the same metabolic derangement. So unless you see them in toto, you will not be able to identify them. And most of these partial varieties are actually missed in the clinical practice. The generalized varieties, they don't get missed because of the overt manifestations. And I mean, right from top to bottom, you will have features. But the partial ones are the ones which actually have the problem. So these are the 4 different subtypes: the generalized and partial variety, the congenital generalized or acquired generalized, and these are the mutations of the particular genes. And partial ones, the LMNA is the commonest one where there are mutations to it. And basically, when you have lack of fat, your triglyceride storage is actually not happening, and it goes to the liver, it goes to muscle, it goes to all other tissues. So you will have most of the metabolic complications. Sometimes, very rarely, the acquired partial may have less manifestations, but those are rarer ones, depending on what is the extent of involvement. So this was a table which looks at the different types. Basically, just remember generalized and partial, and can be both genetic or acquired. And what are the comorbidities? The comorbidities are the same. Key metabolic features being severe insulin resistance, elevated triglycerides, ectopic lipid deposition, poorly controlled diabetes and complications of diabetes. Another clue being hyperphagia. As I've said, these are all typical symptoms which may be there in a type 2 DM also. Hepatic steatosis, hepatomegaly, and progression to cirrhosis. Unusual feature is a proteinuric renal disease. They may have more of FSGS or mesangial glomerulonephritis, and lot of cardiomyopathy, cardiac failure is common. Episodes of pancreatitis because of the triglycerides, and infertility and hyperandrogenism. So most of the common metabolic features which you would see with any other type 2 DM also are there with the lipodystrophy. Looking at what are the, say, overlapping clinical features between all these conditions. We'll have some discussion after I just present this. The lipodystrophy, early onset of diabetes, poor control, low or normal BMI, high insulin requirement, and atypical features, and muscular look because of it. One of the key factors which suggests a diabetes is regain of fat after proper therapy. Clinical clue is, suppose somebody comes with osmotic features, weight loss, you manage them well. Maybe A1C is not improving, but diabetics generally tend to gain weight, gain fat. That is the commonest observation. They may improve partially, but not getting that will give you a clue that it is lipodystrophy and not the diabetic. So important to consider that. Acro sometimes can have almost similar features because of the clubbing, because of the acromegaloid features, the prominence of the forehead and other things, but they have predominantly hypertension also associated, seborrhea associated, which may not be there with these. Arthralgia and galactorrhea, again, typical features of acro do not see in these patients of hyperandrogenism or lipodystrophies. PCOS, HERAN, and insulin resistance syndromes, definitely there may be some overlap here. Again, it is almost a severe insulin resistance with them, acanthosis and acne, but most of them are obese, and in some varieties, the lipids may be normal in some of them. So if some of these conditions are actually so overlapping in the clinical practice, to identify or to label, there may be a long duration of observation will tell, and some of the, say, I would say documented clinical features will help in identifying or at least ruling out some of these. Any comments or questions from the faculty here?
No, so Hari, I do not know whether you will discuss that, but doesn't it sound conflicting that we say insulin resistance is caused by excess body fat? Obesity is associated with insulin resistance. Now you're saying there's no body fat, no, there should be no insulin resistance. This individual should have been the most insulin sensitive individual. So why is it so? Do we understand that? Will you be discussing that?
I will not be discussing, sir, but that's actually the beauty of the fat, that the lack of fat and excess fat, both are leading to the same metabolic outcomes, is actually the key, one of the key messages of this case presentation. It is like, you don't have a fat, the fat goes to all over the other places causing dysfunction. Whereas you have excess of fat, all adipokines will lead to the same dysfunction. So it is extremes of both will lead to the same, final outcome is the same between the two.
I think you earlier said that excess of fat, because that is already getting deposited into the muscle, into the heart tissue, into the pancreas. So I think that excessive amount of fat, say through the liver, is also inducing huge amount of insulin resistance. Sir is very right that because there is no fat towards the periphery with adipose tissue, because there are no functional adipocytes in lipodystrophy typically. So fat, excessive fat is going into the muscles, that is also inducing huge amount of resistance. So both way it is true. Dr. Sahai, any comment? Okay.
The fat is missing from the adipose tissue where it has to be there.
Yeah.
And because of that, it is going into ectopic places and it is causing a problem. That is one issue that we can say. And the other explanation is that because the fat is not being deposited, there is a lot of lipolysis happening in these patients. Because of that, there is a excess triglyceride production and the utilization of this in preference to the glucose. So these are the two simple mechanisms. Just to make it very simple, I mean, I'm just putting it in very simple terms for everybody to understand. It may be a little oversimplification, but that's how I'm looking at it. And to make it very simple to everybody. I hope. I mean, I want the comments of the other experts on this.
No, I think that's fine. So let's go ahead.
Yeah.
There are the two patients, which some of them have shown you initial presentations.
These
The
are two
therapeutic yes, sir. Both are published, both
Right.
of our patients.
Yeah.
Now, okay, unfortunately, this may be a bit small, but the problem with lipodystrophy is actually the treatment, because the treatment almost remains the same. Only thing being, we should be proactively using the thiazolidinediones, where in a common type 2 DM, we wouldn't consider them in the current options. So one of the things which are, I mean, if you look at it, the insulin sensitizers, whatever, metformin, preferable to use along with the TZDs. The GLP-1, there are some reports or some studies also have come up which looked at there are some beneficial effects of the GLP-1, but predominantly it is not on a direct relation with the, say, to do anything with the fat. It is only the weight loss property which has further benefited the glucose control and otherwise. Sulfonylureas definitely are not a drugs to be considered in such setting. Insulin and insulin sensitizers, out of which the TZDs come on top, which is number one as far as the management options are concerned for hyperglycemia. Now, the second most important thing is the hyperlipidemia or dyslipidemia, which is again a major chunk which happens in this. You should be careful about combining the statins and fibrates. Predominantly, they do well with the fish oil and omega-3 fatty acids. So you need to consider them in the clinical practice whenever you have a very high triglycerides. The hyperphagia is driven by the leptin deficiency. So the recombinant leptin is available, but not available here. So, but definitely it is an FDA-approved drug, especially in a generalized lipodystrophy, not in a partial varieties. So there are, I mean, outside, out of India, it is still being used. Some of them, mostly when you are using in the practice, good amount of thiazolidinedione, pioglitazone in our patient. When we started pioglitazone, we started with actually 15 and we have used till 45. And the 45 only has led her to reach to a A1C of a single digit. I mean, the last managed was about 8.6 A1C. We are happy with it because we brought it from 11 to 8. But that was the only drug which could have helped in her managing some of the diabetes with the other things. So definitely, whenever you have a suspicion of lipodystrophy, always, and when you are clinically confirming, because actually there are no diagnostic criteria or to diagnose the lipodystrophies. Clinical suspicion, fat distribution. Some studies have looked at the leptin levels, some studies have looked at the adiponectin levels, but those are the things which are not well validated, not recommended by any guidelines. It is mostly a clinical diagnosis. So when you have a suspicion of a lipodystrophy, you should always consider using the thiazolidinediones. Any comments from
Dr. Hari, I like one of your comment here again on TZs. Typically, TZs are earlier proglitazone or these days pioglitazone are PPAR gamma agonists, which work by leading on to adipocyte differentiation very clearly. I'm not talking of PPAR alpha and gamma together. Alpha might help in terms of reduction of free fatty acids, much better reducing NAFLD and NASH. With TZs, it is true that free fatty acid levels will come down. Little reduction in androgen level may happen. Some amount of glycemic reduction may happen. But in a typical complete lipodystrophy, which is congenital, how do you explain that with PPAR gamma agonist, you will have adipocyte differentiation because you don't have any functional adipocytes at all? The true mechanism of PPAR gamma is because with adipocyte differentiation, you have new adipocyte forming, which are divide of stub-borne fat, and it has better insulin sensitization. That is what is the exact mechanism. In absence of functional adipocytes, how it really helps.
So most of the times, actually, the pickup rate of DEXA is less than 5%. So there are adipocytes and pre-adipocytes which are still present, which will give you some benefit of differentiation and reducing some amount of the free fatty acid utilization. So that is where it is actually useful. Now,
but the way you have shown your patient, which looks like having congenital complete lipodystrophy with very little perianal fat or pelvic fat at all, you think
pelvic
that
and even the extremities, there was a very minuscule level which is preserved.
Yeah, very small level. So you think that there is going to be adipocyte differentiation without adipocytes existing in your patient. Partial, I totally agree. Partial, there is true sense in starting with maybe TZs, pioglitazone, high dose 30 milligram. There is going to be improvement in all ways with adipocyte differentiation, reduction in free fatty acid levels, endogens coming down, HbA1c also coming down, and insulin sensitization happening more so into the liver also because there is a insulin resistance into the liver, typically in lipodystrophy because of additional fat in liver. But the way it is your patient, you said that first time HbA1c came down to single figure without any existing adipocytes.
That was the only reason why I said, because the only drug which the patient was not exposed prior to was the glitazone till that almost 7 years of follow-up. So when we started giving the glitazone, there was some benefit which we could add. I mean, insulin, everybody kept on increasing. Even we also kept on increasing the insulin. There is no doubt about it. But we looked at using the gliptin, metformin, and glitazone. That is where we said at least some other thing which could have helped. And when we looked at the observation, that was the only thing which has helped actually.
Have you had some experience on leptin therapies, sir, Dr. Shubhankar or Dr. Sahai?
No, I don't have. I wish just to add to what you said, while I fully share your skepticism as to the utility of pioglitazone in this individual, theoretically, at least pioglitazone is supposed to cause differentiation of mesenchymal cells into the adipocyte lineage. So there's no statement that mesenchymal cells are absent there. So there is a possibility that even they may respond, but of course, whether they do respond in a significant way, we are not sure.
True, sir. Very true. Dr. Sahai, Dr. N.K. Singh?
I think, sir, Dr. K.V.S. Harikumar was just mentioning about this leptin. So I think I have just heard a lecture 3 or 4 years back at the ADA, but I think it's very, very costly. And is it available in India at all? Any?
No, it's not. Metroleptin.
Because it has been found that it is very effective in such cases. In the tune of everything, all the complications and many things it has been mentioned, but it is not available, and I think it is at present it's theoretical at present. So I think you can proceed now.
So some of the recent advances, still some antisense oligonucleotides for this to basically to reduce the fats. We will skip this. So this is the one, I mean, last but one slide. Flow chart for poorly controlled, definitely this is most important. You look at the compliance of the therapies, the physiological reasons of maybe puberty, other things, type of insulin, storage of insulin, lipodystrophy, any other markers. And basic panel should be considered whenever somebody has got a poorly controlled diabetes. If not visible or if there is no clue found at that level, you should definitely do an endocrine workup, definitely thyroid panel, ONDST, IGF-1, metanephrines, insulin. Try to look at some other condition which may be there in this panel. In some patients, we may have to, as I said, there are case reports of looking at subcutaneous insulin resistance. So whenever you just admit the patient, maybe you give a IV insulin infusion, look at the response rate and look at the glycemic control, and then it is like something like giving you a clue as to what is there, where is the problem. And some genetic mutations and clamp studies, as Sir has rightly said, mostly in the research settings. And finally, when nothing is visible, there are, I'm sure most of you would have seen some patients where nothing is there, we still have to give higher dosages of insulin, and then we just come under the category of idiopathy. Management, we have already discussed. Higher insulin concentrations are there for some of these patients of U300 and U500. Some periods, short periods of admission and IV insulin, and some of the immunomodulator therapies in them. So poorly controlled diabetes is a common problem. Systematic approach is essential to identify unusual causes, and mostly a checklist-based questionnaire is the ideal way forward so as not to miss out anything. Look out endocrine causes, drugs, and other things. IV insulin infusion may sometime help in differential diagnosis. And only one message, if I have to give of this lecture, is only that whenever somebody is requiring more than 1 to 2 units per kg per day of insulin for the control, keep at least strip them, look at the entire spectrum, identify some other condition which may be there. I've finished here. Any
I
final
think, Hari, did you do genetic workup in this for BSCL2? You said no,
No,
because
sir. No,
you
sir.
seem to
We have
have
not
published this case.
we have
in some good
mentioned
internet-
we have mentioned that we couldn't do because actually that time it was not it was not available in RR, and patient was not ready to spend, so we didn't do the genetic.
You didn't for benefit of for all of us and delegates, you didn't talk about clinical criteria, 3 major and 2 minor. Sometimes we go on 2 and 2 when you are not able to get genetic studies and all that. If I correctly remember, early days we used to say 3 major criteria, 2 minor, or 2 major and 2 minor, to say whether we are close to lipodystrophy when we cannot get a genetic study done. I remember about 10 years ago, I had one patient who typically was lipodystrophy. We, based on clinical presentation, almost like your patient, what you have presented, lean, thin, female, and she was requiring close to 130, 140 units of insulin without any clinical improvement. She was also, I think, 5, 6, 7 years long-standing diabetes throughout, poor glycemic control without ketosis prone. So I remember that time we clinically we also thought it could be lipodystrophy. We couldn't reach to a final diagnosis because we didn't have any genetic access to that time. We were not having even DEXAs in our hospital. So we, based on overall examination, and we said that there seemed to be 3 major criteria in the form of lipodystrophy, which was obvious trunk limb, which was typically there in that female, and she also had that acromegaly type, or maybe typical symptom of gigantism, facial expression and all that. And she had a ultrasound which was showing fatty liver and raised enzyme, raised triglycerides. And we said 2 criteria clinically and 2 criteria minor. We concluded that it could be lipodystrophy, and we could publish that patient. One more patient I'll actually learn from this very learned panel. I have one type 1 female with me for 15 years. Early days, she was with Dr. Anup Mishra. She has been admitted with me over last 5 years, at least 7, 8 times. Every time she goes in DK, she's BMI close to 18, typical type 1. Only problem is that now, learning from your one of your slides, that typical subcutaneous insulin resistance, Whenever she comes to my clinic, her sugars are always 300, and she's already on almost 150 units of insulin. Almost 30 units she takes rapid, either Nomorapid, sometimes logs and Humalogs, and almost close to 80 to 100 units of. I tried everything. I tried with NPH early days, tried with Glargine, tried with Tresiba. Nothing has worked, and her sugars are never less than 300. I referred it to Dr. Madhu, to his center. They also did some initial workup. Insulin receptor antibodies, everything is negative. And whenever we admit her in DK, we get close to 100 units. Then she comes out to DK. Her sugars are anything around 200, 250. But moment she goes back home, she's back to almost 150, 160, 170 units, and sugars are always more than 300. I don't know what type of type 1 she is. She is not typical lipodystrophy. She is typical type 1 because early days she was actually diagnosed for the first time by Dr. Mishra at his center. She was put on pump. She lost that pump. And after that, she's not keen on going on pump. Subcutaneous insulin, 5 doses she takes every day. Sugars are always close to 300. HbA1c has never been less than 10.
Two quick comments. I have even now we have I think 3 case reports published of type 1 with lipodystrophy in PubMed. Type 1 with lipodystrophy, 3 case reports, and subcutaneous insulin resistance is a quite reasonably documented entity in some.
I think
Yes, sir,
we have 5 minutes. We can conclude this. So I would like to have some take-home message from Dr. Subhankar Chaudhary and Dr. Rakesh Sahai also. And Dr. Chawla has given a very important inputs on these cases. So Dr. Subhankar, sir.
Yeah. So I think we all need these oddities once in a while. Fortunately, they are not common, but we need to keep our eyes open, especially when someone is requiring unusually large amounts of insulin and is non-obese or lean. And then the physical examination, as I've already mentioned, is so very important. Treatment of lipodystrophy, especially generalized lipodystrophy, is a big challenge. I don't think we have any clear answer, even with the availability of metrileptin, which is a leptin receptor agonist. I don't think we can solve all the issues related to it, but we can try and help our patients, and we should always be with our patients and always try and have as positive an approach as we can, so that we don't make our patients or the family also feel let down. We should always give them some hope. These are a few words that I wish to share with all our audience across the country.
Hari, did we do an echo to look for hookam, which is quite common? Because they have ectopic fat even on septa, and they are they are known to have cardiac failure.
Cardiomyopathy is HCM is quite common.
Yeah,
I have not done that.
Also, if we combine pioglitazone with such high doses of insulin, do the risk of heart failure increases in this category of patients because they might be having some cardiac involvement also?
Mostly we started because actually of a young age group. Mostly they are in the second decade. So that is why, and as I said, I mean, at least to get some glycemic control to prevent some of there was a microalbuminuria already happening. So that was the only reason. Yes, definitely a echo could have been considered, but clinically there was no features to suggest edema or a heart failure.
Yeah, Dr. Rakesh Sahai, sir, your take-home message from this case.
Yeah, I think the important take-home that we have from this patient is that, any patient who requires large doses of insulin, we should keep our eyes and ears open. We need, there are many challenging situations. I mean, not all of them turn out to have this sort of a problem, but it could be just storage of insulin not being adequate, the injection technique not being good, lipohypertrophy being there at the injection site. So I think all those have to be kept in mind. And after teasing out all those things, after excluding all those things, we need to, we may end up with some patients who have this sort of a problem. And it is always a challenge to identify this. And I think it is rewarding when we understand the problem and we are able to, even though we're not able to treat it effectively, we may not have all the tools available, but I think it does give us a sort of better understanding of the problem and helps us in at least managing them better. That's
Yeah, Doctor. Thank you, sir. Dr. Jethwani, sir, can you conclude this session and then vote of thanks?
Yes. Hello.
Yeah.
message that
Go.
I
Go on.
would say. And I think Dr. Hari has done a wonderful presentation.
Yeah, Dr. Jethwani, please go on.
Okay. So I think we have learned a few important points that if your patient is requiring very high doses of insulin, as Dr. Rakesh Sai told, after ruling out the common factors contributing to that high dose insulin requirement, you have to keep in mind this kind of presentation of lipodystrophy also, and you have to do thorough clinical examination and then go for further tests to rule out, because this is a condition where it will be very difficult to control diabetes. And as very well highlighted, the role of glitazones is very good in that category of patients. So always you have to look for this kind of lipodystrophy, particularly if the insulin requirement is very high and young patient is there where BMI is less. So I think we conclude our session here, and I thank Dr. KVS Harikumar for a very excellent case, interesting case. We learn lot many things from your case, and all the faculties, Professor Subhankar Chaudhary, Professor Rakesh Sai, and Professor Rajiv Chawla, for their valuable time and insights about how to approach different cases or difficult cases of diabetes in routine clinical practice. With that, I conclude this session here. Good night to everyone, and we will meet next month with next interesting case of diabetes by some other prominent.
Excellently worked up case, I must say. Excellently pursued and worked up case. Of course, lipodystrophy these days is not that uncommon, but the way you worked up and presented different aspects clinically for a clinician not to miss these things whenever and raise alarm when to pick it up. I think it has been beautifully done. Thank you.
So I will end here, sir. I will end here with just last comment. Yeah, so I think Dr. KVS Harikumar, this is a very, very exciting case, very fascinating case. And it has been said that the lipodystrophy syndromes are a group of fascinating diseases that are caused by the mechanisms that disrupt the predominantly the adipocyte differentiation. So I think this was a nice learning and very clinical points have been discussed. So I'm really thankful to you and all our learned moderators. I think, thank you, sir. We will meet again. Thank you very much. Good night.
Thank you, sir.
Everyone. Thank you, everyone, for sparing your valuable time. Good night, everyone.
Thank you,
Great
sir.
effort from Rssdi. Wonderful.
Thank you, sir.
Thank you, sir. Good night, everyone, sir.
Good night.
Good night. Thank you, sir. Good night.